Assalamu alaikum. I'm Dr. Mahmoud Al-Shikari, a medical consultant. We're going to speak about electrolytes, sodium and potassium mainly. Today, our lecture is potassium abnormalities. In this lecture, we're going to speak about hypokalemia and hyperkalemia. In hypokalemia, we're going to speak about its causes, manifestations, complications, and management. And the same, we're going to speak about hyperkalemia causes, manifestation, and management. Potassium disorders. The maintenance of normal serum potassium at normal level, which is 3.5 to 5 millimole per liter, is vital for health. Intracellular to extracellular potassium ratio is 35 to 1, so it is the main intracellular cation. 2 to 1 ratio of intracellular to extracellular water, and 98% of potassium in the body resides within the cells. And for the total amount of potassium is usually on the order of 50 millimole per kg of body weight. Potassium is essential for a number of critical body functions. Enzymatic reactions that regulate protein synthesis, glycogen synthesis, cell growth, and cell division is dependent on potassium. In excitable cells also, it is vital. Cardiac myocytes and skeletal muscle contractions is dependent on potassium. The relationship of intracellular to extracellular potassium concentration is critical to establish the resting membrane potential. So, the factors regulating potassium balance is vital to know because these have highlight on manifestation and it have impact on management. So it is vital to know these factors. First is insulin. Second is beta-adrenergic activity, acid-base balance, magnesium, osmolality, and thyroid. The vital role of insulin in potassium metabolism is as follows. It regulates the distribution of potassium between intracellular and extracellular spaces. Insulin acts after meal, as you know, it's excreted after meal. An increase in serum potassium stimulates insulin release from beta cell of pancreatic islets, and this is independent from glucose stimulation. So insulin increases potassium uptake. Once excreted, it increases potassium uptake into the cells, primarily muscle cells. And this is again independent of its effect on glucose uptake. So generally saying that insulin increases uptake of potassium into the cells, and it also increases the uptake of glucose into the cells. But this is by independent mechanisms. But the channels for potassium and glucose opens at the same time. The second regulator of potassium is sympathoadrenal system, and mainly beta-adrenergic activation. It is regulates the distribution of potassium between extracellular and intracellular spaces. Beta-2 receptors increases potassium uptake into muscles and fat cells. Epinephrine, which also have alpha-adrenergic effect, is associated with transient increase in potassium release from the liver before a more prolonged period of decreased potassium mediated by stimulation of beta-2 receptors. So alpha receptor stimulation is short-lived, so the main long-term effect is beta-2 activation. So this diagram shows cellular potassium shift. This is the cell, as you see, and fall in potassium increased by, so shifting to intracellular, increased by insulin activation, beta-2 adrenoreceptor agonist activation, alkalosis, and alpha receptor antagonist. But excretion from cell outside is increased by acidosis, in contrast to alkalosis, hyperglycemia, which leads uh, and beta 2 adrenergic receptor antagonist, beta blockers, and alpha receptor agonist. It increases also by increasing osmolality and exercises. So now we're going to speak about hypokalemia. Hypokalemia, the causes of it is defined as potassium less than 3.5. Decreased potassium intake is on the top of the list of causes. Increased potassium losses like non-renal and renal causes. Potassium loss can be renal, such as in tuberous interstitial disease, diverticules, etc., and non-renal like skin and GIT. Increased blood flow and distal tubule delivery like diuretics, osmotic diuretics, and salt wasting nephropathies. Increased secretion of potassium is mainly due to mineralocorticosteroid excess, like primary hyperaldosteronism, and an activation of the RAS system. So renal causes of hypokalemia may be due to increased distal flow and distal sodium delivery due to diuretics, osmotic diuretics, or salt wasting nephropathies, or increased secretion of potassium by mineralocorticosteroid excess. Any activation of RAS system at any level can lead to hypokalemia, like primary hyperaldosteronism, familial hyperaldosteronism, or secondary hyperaldosteronism, Barthel's, Gentleman, Cushing syndrome, etc. Renal potassium loss can be also due to aberrant mineralocorticosteroid excess. This, in such condition, there is an condition similar to activation of our system, but it is not due to hyperaldosteronism, like aberrant mineralocorticosteroid excess, genetic deficiency of 11 beta hydroxysteroid dehydrogenase enzyme, and it can be acquired or congenital, acquired due to licorice intake. Or some condition like Liddle syndrome, which is genetic condition called which is autosomal dominant, and in this such condition, the sodium channels keeps open for autosomal dominant mutation. Or distal delivery of non-reabsorbed ions like vomiting, angiotubular suction, proximal renal tubular acidosis, diabetic ketoacidosis, glucose snuffing, which is form of addiction, penicillin derivatives like naflicillin, penicillins, and carpicillins. Other causes of hypokalemia, redistribution hypokalemia. Redistribution hypokalemia occurs in insulin excess or in alkalosis. It's also in stress, which leads to beta adrenergic activation, which leads to shifting intracellular. Alpha adrenergic antagonist, hypokalemic periodic paralysis, which is seen in hyperthyroidism, thyrotoxicosis, or in hypothyroidism also. Hypothermia and barium swallowing. Theophylline can lead, especially in overdose, can lead to hypokalemia and caffeine intake. Pseudohypokalemia can be seen in extreme leukocytosis. Diagnosis. First, you have to rule out pseudohypokalemia or redistribution hypokalemia and make sure about potassium depletion, whether this is renal or non-renal, like GIT or skin. The clinical manifestation is dependent in all metabolic conditions, dependent on magnitude of deficiency and the speed of development of deficiency. So, on the top of the list is on clinical manifestation is hypertension. Blood pressure increases by 5 to 10 millimeter mercury in cases of hyperkalemia, and it can lead to cardiac arrhythmias and digoxin toxicity. Arrhythmias seen if serum potassium falls below 3 and especially augmented when there is concomitant ischemia or hypercalcemia or patient taking digoxin. Hypokalemia slows potassium conduction, leading to prolonged repolarization phase and accounting for the characteristic ECG finding, which is broad and flattened T wave and appearance of the U wave. The patient with hypokalemia are prone to tachyarrhythmias. In contrast to patients with hyperkalemia, they are prone to bradyarrhythmias. Neuromuscular manifestation of hypokalemia, it affects all muscles, skeletal and smooth muscles, and myocardial muscles. Smooth muscles can lead to ileus, this is common intra-hospital communication, and skeletal muscles can lead to weakness, cramps, and even paralysis. We call it periodic paralysis sometimes in such condition, in certain conditions like hyperparathyroidism. Paralysis can associate with fasciculations, and in severe cases, we can see rhabdomyolysis. In severe cases of muscle paralysis, it can affect the diaphragm, leading to type 2 respiratory failure and death. Clinical manifestation of hypokalemia can also affect the endocrine dysfunction and can lead to glucose intolerance due to decrease in insulin release and sensitivity. It can manifest as decreased growth in childhood. Renal manifestation of hypokalemia can be functional and structural. Functional disturbance include decreased GFR, increased proximal tubule amine oxygenesis, increased sodium potassium reabsorption, and net acid excretion. Hypokalemia also has a negative effect on aldosterone synthesis in zona glomerulosa. Nephrogenic diabetes insipidus, one manifestation of hypokalemia. It can also lead to decrease renal blood flow and increase vascular resistance. And this is behind the hypertension development. Getting vasopressin resistant, ammonia production, metabolic alkalosis, and polyuria, phosphaturia, and hypocystinuria. Structural changes of hypokalemia is renal cyst and interstitial changes. The treatment of hypokalemia first prevent life-threatening and or chronic consequences like growth retardation. Replace the associated potassium deficiency, correct the underlying cause of hypokalemia. Treatment urgency of therapy depends on severity, speed of decline, associated clinical factors like cardiac disease, digoxin therapy, etc. Caution: severe redistribution hypokalemia should not be taken cautiously because this can lead to hyperkalemia, which is a medical emergency, and sometimes if we fail to correct hypokalemia, we need concomitant magnesium replacement to control hypomagnesemia. The treatment of hypokalemia is by potassium supplements, which can be oral or IV. Intravenous safety at rate of 10 millimole per hour, 20 millimole of KCl increases potassium about 0.25 millimole per liter. More than 20 millimole per hour replacement needs central line. So you need by 1 liter of normal saline, you cannot give more than 20 by 500 milliliter normal saline, you cannot give more than 20, and you cannot give more than 20 in a peripheral line, and you cannot give more than 20 in 2 hours. Causes of hypokalemia. If you need a higher dose of potassium, more than 20 per hour and more than 20 per 500 cc, you have to use a central line. There is a certain group of hypokalemia which we have to know about is causes of hypokalemia. We have divided them to non-renal and renal causes, but there is set of causes. We call them hypertensive syndrome, hypertensive hypokalemia, hypokalemia with hypertension and metabolic alkalosis. And then on this condition, there is activation of RAS system or similar mechanisms. Like Liddle syndrome, which we have studied this pathway by studying the renin level, aldosterone level, and renin aldosterone ratio. In Liddle syndrome, we have spoken about it, which is aberrant neurotic corticosteroid excess. Uh, there is low renin and low aldosterone, and Liddle's characterized by autosomal dominant mutation in which sodium channels keeps open for unknown reason. So it leads to low renin and low aldosterone, but there is sodium retention and ultimately potassium excretion, and this leads to hypokalemia, hypertension, and metabolic alkalosis. Licorice ingestion and aberrant mineral corticosteroid excess, also associated with low renin, low aldosterone. It inhibits 11 beta hydroxysteroid dehydrogenase enzyme, which converts cortisol, which has high mineralic corticosteroid effect, to cortisone with low mineralic corticosteroid effect. Once this enzyme is insufficient, cortisol is accumulates and it acts like mineralic corticosteroid. You should know that all steroids have some mineralic corticosteroid effect in high dosage. Next is renal tubular stenosis and renin secreting tumor, which is associated with high aldosterone and high renin. Adrenal hyperfunction or tumor in such condition, aldosterone is the only is high and renin is low. Ectopic ACTH leads to high cortisol level but low renin, and some condition called glucocorticoid remediable hyperaldosteronism. These are the explanation of what I have said. There's hypokalemia with hypotensive syndrome and again metabolic alkalosis. Like diverticules, Barter's and Gitelman. Both Barter is, we call it congenital loop diuretic syndrome, and Gitelman called congenital thiazide diuretic syndrome. These are tubulopathies. Hyperkalemia, defined as potassium more than 5. Causes pseudohyperkalemia and redistribution hyperkalemia. Pseudohyperkalemia can be seen in thrombocytosis, leukocytosis, ischemic blood draw. So this is fake result. Redistribution hyperkalemia can be seen after exercise and metabolic acidosis, insulin deficiency, hypertonicity, and alpha-adrenergic activation. The rare cause of hyperkalemia is excess intake, but the commonest cause is impaired renal potassium excretion and usually GFR stage 4 and 5 to less than 30, less than 20. Endogenous or exogenous potassium accumulation and the drugs that impair potassium excretion can lead to increased hyperkalemia in case of decreased GFR. Increased cell breakdown also leads to hyperkalemia because it's the main intercirculatory like rhabdomyolysis and hemolysis. In decreased excretion in renal failure, potassium sparing diuretics, and hypoaldosteronism. So these are the causes and mechanisms behind them. Manifestation of hyperkalemia, it is usually asymptomatic, and this is the danger of hyperkalemia because it's a medical emergency and it can kill patient without any symptoms, so it can cause sudden death. So having no symptoms in the presence of hyperkalemia is not reassuring. Skeletal muscle weakness or paralysis can happen, serious cardiac complication can happen, and at there is the polarization effect on the resting membrane potential and potassium channel conductance is increased, leading to a classical ECG changes of hyperacute, peaked and tinted T wave, different from ischemic one, and this is associated with rapid repolarization. The maybe disproportionately, the clinical manifestation may be disproportional to the ECG changes. But it is generally, we're going to speak about ECG changes in a minute. But the other cardiovascular is T-wave abnormalities and bradyarrhythmias, in contrast to hypokalemia. Neuromuscular, again, EDS, paresthesia, weakness, paralysis, and renal, decrease ammonia production and metabolic acidosis. So what are the ECG changes? At first, we see tinted peak T wave at level between 6 to 7. If this increases 7 to 8, we start to see flattening of the B wave, prolonged PR interval, depressed ST segment, and peaked T wave. Above 8, we're going to see atrial standstill, prolonged QRS duration, and further peaking of the T wave. More than 9, we start to see sine wave pattern, which is pre-arrest sine wave pattern. So these changes of ECG is most likely linked to the level of the potassium and the speed of how it develops. As you can see, tinted T wave and widening the QRS complex, depression of the PR of ST segment, and this is sine wave. Hyperkalemia, like acetylcholine, result in sinus bradycardia, heart block, loss of B wave, and prolonged QRS interval are all seen in cases of severe hyperkalemia, usually more than 6. However, ECG is not a sensitive indicator. The sensitive indicator is the number. Once you have potassium more than 6, you have to treat. Because cardiac arrest may occur suddenly and without warning. So the management of hyperkalemia consists of 3 lines. First line, and which is the most important and should be done while you are repeating your result to make sure that they are correct or incorrect, you have to protect the heart. The second is shifting of potassium to its natural habitats, to intracellular space. And third is chelation from the body, which is the definitive treatment. So how we can protect the heart? We give the antagonist of potassium, which is calcium gluconate, 10% solution in 10 milliliter of it over 10-minute infusion. The onset of action starts within 1 to 3 minutes and it can continue up to 1 hour. To shift the potassium from extracellular to intercellular, we back to the physiology. We have spoken about first insulin, beta activation, and alkalosis. So we use insulin, regular insulin, 10 units in 5% or 50%, regardless which concentration of glucose you want to use. You put for every 3 gram of sugar, you put 1 unit of insulin. So if we use, for instance, 5% glucose, 500 cc, where you can find 25 grams of glucose, you need, multiplied by 3, you need 8 to 10 units of insulin. And infusion, the onset starts within infusion over 2 hours. The onset starts within 30 minutes and it can continue up to 6 hours. Nebulized salbutamol can be used, but it's used in higher dosage than which we use in asthma patient, and we can use finally sodium bicarbonate to cause an alkalosis, which also shift to intracellular volume. The final is removal from the body by hemodialysis, or in chronic conditions we use the potassium sparing resin, which we call it K-oxalate, which binds, which is taken as powder, 60 gram BO. It binds the potassium to the GIT, and it can then excreted with a stool, and you can use adjunctive diuretics, laxatives for to prevent constipation. This is all about hypo and hyperkalemia, and thank you.